Ontogeny of EEG. Myself, Dr. Aravind, the moderator, Dr. Ramsekhar Menon, sir. So, I will be presenting. My scheme of presentation will be mainly first introduction. I will explain about brain maturation and EEG evolution according to ages in different ages, and finally I will conclude. So, what is ontogeny in EEG? So, the EEG pattern also evolves when the child grows. So, it has different patterns when it pre-term, term, and when it was term, and when it grows, like when it crosses different periods like infancy, childhood, and until it attains adulthood, the EEG also evolves. Uh, so in old age also there's an evolution of EEG. This changes reflect what it actually reflects is the maturation of and organization of the neuronal circuits. Uh, According to the brain maturation, the EEG also there will be changes will be there. So that is the thing. What is ontogeny is. So I'll be explaining mainly about on that. So coming to the history, the first EEG in studies in children were done by Hans Berger. He's a German psychiatrist. It was done during the period of 1929 to early 1930s. He is the one first found that age-dependent changes. Then it is followed by Rufus Brissac. He's a French pediatric neurophysician, and he also contributed many works. After that, that EEG in neonatology has been recognized as subspecialist field. So further development was made by Hughes and his workers, and his co-workers. So they found the various patterns like in the different patterns in premature and mature and term babies, and how it evolves further. So then coming to brain maturation, what happens? So when our brain matures, so first thing is about neuralization. Then the neuronal proliferation takes place. So after 7 to 8 weeks, the neuronal differentiation takes place. That from initially that neuronal migration takes from uh, germinal zone, from the periventricular germinal zone, and it migrates to the cortex. There will be two types of migration, like radial migration and tangential migration. After migrating, there will be a synapse formation between the neurons. That will be pruning of that proper synaptic pruning will occur. This is called lamination of the neurons. So after this lamination only, the cortex and gyrase sulcus will form. If any problem in this migration, there will be a cortex lamination will be poor, and it will lead to malformation of congenital development. So if when it occurs properly, the EEG changes maturation also will be occur properly, and we can see it in EEG. So if any defect in that, the EEG will show delayed ontogeny or abnormal ontogeny. That will I'll be explaining in further slides. So main concept is when the child changes from preterm to then finally term in infancy, then adult. So during that process, EEG also shifts to various patterns. Initially, if you see the preterm EEG, it will be more of discontinuous activity, and it will when it becomes adult, it becomes continuous pattern. That is the main concept. Also, from initially from theta delta complexes to adult predominant PHR rhythm will change from theta delta complexes to from adult form. That is alpha rhythm. That also will evolve over time only. That is the main key concept. That how it occurs, I will explain in here. First, I will be explaining about EEG in preterm and neonates. Uh, that montages of preterm is different for neonatal montage is different from adult montage. So here we uses because neonatal head is very small size and the area is small. So we are using some specialized chains. So mainly we'll be concentrating on the transverse chain because that many of the changes occurs in the vertex of the child, the brain. So mainly we'll be having transverse chain, and this we'll have sagittal and parasagittal chain. The common thing we are using electrodes we will use like we will not use like 10-20 system of the adult. We will not include every electrode. We cannot keep every electrode in the child's brain. If we keep more electrodes also, there will be a more contamination will come. So two to three electrodes will pick up from the same area. So it is ideally to keep reduced system. That is the reduced restricted system in neonatal thing. So commonly we use this frontal polar electrodes. Then we have that is sagittal and parasagittal montage like FP1 C3 and O1 and FP1 T3 and O1. And in transverse we will have from either from right to left or left to right. You'll have T4, C4, CZ, and then C3, T3. This chain will have. So here I will be showing about the neonatal model. See, from here it is a left-sided chain. Left-sided chain is mainly like FP1 and FP1 T3 and T3ON. That is a temporal chain, and that is parasagittal FP1 T3 C3 and C3ON. That is left-sided. Similarly, it will have for right-sided will have chain and special chain for transverse chain like T4 C4. C4 CZ and CZ C3 and C3 T3. Like that way we have transverse chain. Other than that, important electrodes we keep are ocular electrodes, like to look at the eye movements. That is left orbicular oculi and right side ocular chain. Then we'll keep chin electrodes and leg electrodes. Chin electrodes are mainly from see the atonia or chin muscle activity. So and leg also we will keep one electrode. And other thing is we will monitor respiration and abdominal. Abdominal electrodes are fit mainly to main respiration only, because the child will have various type of respiration in different phases. Like in REM sleep, it will have irregular breathing, and quiet sleep, like in REM, it will have regular breathing pattern. So irregular. So for identifying respiratory pattern, we will have specialized electrodes. The other thing is ECG electrode. It is common. So when we go before going to the interpretation of neonatal EEG, what are the things we must know? So before going into interpretation, first thing we must know is the age of the child, and then we have to go step by step process. First is age, then only we have to go into the background activity and synchrony, reactivity, waveforms, and sleep. So age is very important in child, because I will explain here. So because there are two types of age: chronological age and conceptual age. What is chronological age? If a child is born, after that we are giving age. So 1 month old child, after birth, it is some age, 30 days after birth. That is a chronological age. The chronological age will be different for different infants. Suppose the child is born pretermly at 8 months, if you imagine. The chronological age will be like after 2 months, the chronological age will be 2 months at the time. But actual the brain maturation does not depends on chronological age. It has some stable. So brain development happens smoothly either in vitro or out, or following delivery. So we must take the conceptual age into the account. The conceptual age is simple, that from the day of conception. That is the main concept. So that we can calculate from first day of menstrual period. So what main concept is gestational weeks. That the child is born of for a full time means 40 weeks gestational age. Along with it, we have to add chronological age. Actually, we have to exact conceptual age will be 2 weeks, will be less than that, because the conception will take place after 1 or 2 weeks. That's the actual time of fertilization after the LMP. So for that, so conceptual age will reflect the proper maturity, and it so from that only we have to interpret the EEG. So main thing is conceptual age is addition of the gestational age and chronological age. Postmens.
Conceptual age -2.
-2 weeks.
Conceptual age.
So from the LMP we are calculating post-menstrual age. From that, if we -2 weeks, exactly conceptual age will come. So after identify age, the background. In the background, what we see is mainly continuity of the background, and then we must see interburst interval and the amplitude also, and the voltage amplitude. We have to see many things. So in the preterm, so the EEG change first occurs in 24 to 30 weeks. That time there will be no differentiation between awake and sleep stage. The EEG will be same in all phases. So it will be more of discontinuous pattern. It is not like continuous pattern in adult. So here continuous means the waveforms are coming continuously. Discontinuous means some waveforms will come like burst, and there will be some phases of attenuation. That phases is called interburst period, and then again some burst will come. EEG will be like this discontinuous pattern in both awake and sleep stage in early preterm stages. So what is the voltage criteria is the high voltage, that burst will be high voltage delta, that will be around 550 to 300 microvolt. This voltage is very important. With low flat, this attenuation will be less than 25 microvolt. When that time only we will tell it is a trace discontinua. So when the child matures, when it attains late preterm, when it comes to 31 to 35 weeks, that sleep cycle we can see in the start to appear in the EEG, such that how it means in the awake stage will become tend to become continuous, but sleep stage still will be discontinuous. That I'll be explaining in the following slides. So this is the trace discontinue. It is seen in preterm. This trace discontinue will be present both in awake and sleep. So there is no difference in between. There will be no difference in between awake and sleep in the preterm. It will be like continuous pattern. It will be like same pattern. We cannot differentiate patterns in preterm EEG. So trace discontinue, we can see that interburst interval, that it's a burst of high voltage delta of 50 to 300 microvolt, followed by some period of attenuation less than 25 microvolt, and followed by again burst. So this interburst interval is very important. So in early preterm, this interburst interval will be large at around around 60 milliseconds. Then it will decrease and come. So when the age advances, the interburst interval will decreases and the waveform tend to become continuous. Yes. Then here, so this is the interval at the 24 to 27 weeks. It will be up to 60 seconds. That interburst interval will be. So it will decrease slowly as the fetus matures, and by term it will become less than 10 seconds. And moreover, it will become continuous in awake period. So this, if you look at closely, this will be looking like a vast attenuation pattern. But in preterm baby, it is a normal thing. So how to differentiate between burst attenuation and trace this pattern is burst attenuation pattern burst will be more of like epileptic form. We can see the spike component and followed by slow wave component in the burst. It is here the burst are more of high voltage delta component. So, so we must differentiate things. So if we see a child with suppose 1 month chronological age, if we see this pattern, it is abnormal because this thing will present only in the early preterm period. When the child matures, this pattern will disappear.
One of the things we're talking about 1 month old baby state pattern. Also have to look at the voltage of that year of attenuation. The voltage is less than 5 microvolt, would be considered as a degree of suppression. And the suppression periods can vary depending upon the degree of ancestral. If the child has had severe hypoxic, so the periods of discontinuity, the periods of suppression will be so prolonged. And interrupted by high voltage bursts of stops and occasionally spike and polyspike and channels. So the important thing is in transit discontinue, the sleep-wake transitions will not be appreciated. So once the child reaches at 1 month, you expect to see sleep-wake transitions. You won't be seeing sleep-wake transitions. There is a severe degree of consequence.
So another thing is, if you 1 month old child, if you see like this pattern, we must main thing is see the voltage. So if it is burst attenuation pattern, the voltage will be very much suppressed. That interburst voltage will be less than 5 microvolt, and it is seen in like encephalopathic childs like that way. So this trace discontinuous normal pattern is seen in preterm child. So then when we come to term, we will start to appreciate sleep wake transition. So wake period will become mostly it will become it will tend to become continuous background. But in sleep still it will be discontinuous, but the voltage is different. But it will become from trace discontinue, it will become trace alternate in sleep, such that it will be like high voltage followed by low voltage with the intervening period of low voltage period. Here the low voltage background is more than 25 microvolt. That is the difference. So this trace alternate pattern will be present up to 44 weeks in non-REM sleep, and then it disappears. So when the child matures, when it becomes 1 to 2 months, the trace alternate also disappears, and the background tends to become continuous in all states. So this is the trace alternate pattern. So here you can see a burst of delta followed by attenuation period, but here the voltage will be more than 25 microvolt. If this is called trace alternate pattern. So when the child in the term, you can see what happens is the trace discontinue changes to continuous pattern. Continuous pattern tends to become continuous in awake, and in sleep pattern it changes into trace alternate pattern. That is the thing. So here it's an example. Here 1 month old child. So the conceptual age is 44 weeks. So it's a sleep record. Here you can see that burst of delta wave, followed by you can see a period of attenuation. But here you can see small change voltage fluctuation here also. So it is a record at the sensitivity of 15 microvolt per mm. So we here this voltage is around more than 25 volt. So this is the trace alternance pattern. So period of burst of delta followed by low voltage of more than 25 microvolt. It is a trace alternate pattern seen in sleep record. So it disappears by 44 to 46, it disappears. So then synchrony, how will be the synchrony and reactivity of that child? So in preterm and term child will be mostly like largely asynchronous in very preterm, and synchronicity also will increases as the child matures, because the corpus the
One of the problems with calling this a trace or pattern is the EOG, the electro-optical.
I'm
I movement also happening. Uncertain whether this is a REM sleep record. So the awake to sleep transition is, there is definitely not awake. You're not seeing much of and movement artifacts. But there is a eye movement also happening. So I don't call this a mixed voltage irregular passage, being more often than sleep. It's not typical class 7, it's what you showed. The previous example, that is more typical class 7. This because I only red flag is the presence of these isotones, which might indicate this is a REM sleep.
Then another thing, then in the CEG, so we have to look at the eye movements also, but it looks like trace alternates, but here the eye movements are there. So it can be REM sleep also, because the eye movements are there are alternating eye movements occurring in the electrocardiogram. So it can be some mixed voltage REM sleep. It can be phase transition phase also. So we have to main thing is like trace alternance patterns. We have think of it will be like period of burst of delta followed by the period of low voltage of more than 25 microvolt, followed by again the burst will come. That's a trace alternance pattern. Then so synchrony will increase, because when the child matures, the corpus callosum get the interconnectivity between two hemispheres happens. So when the corpus callosum will mature good, and when the child grows, when the child ages, so synchrony also will become between the two hemispheres. The proper synchrony will become by 1 or 2 years. So in when we look at the very preterm, the waveforms will be morely asynchronous between the both hemispheres. So when the child when it reaches term, it will become nearly synchronous, but minor asynchronous can still be there. So full asynchronous patterns will come only by 1 to 2 years. So sleep. So we can identify the sleep wake transition only from that late when the child reaches only term. Until that, as I explained, it will be like trace discontinue pattern. So when the child reaches term, we can clearly identify the sleep wake cycle. So in the term sleep, we can identify two sleep. That is REM and NREM. We'll usually tell in neonatal, we'll tell it as quiet sleep and active sleep. Active sleep is a REM sleep. Quiet sleep, it is a non-REM sleep. In non-REM sleep, that's a quiet sleep. You will see two types of pattern. Either, as I explained, trace alternate pattern. Otherwise, you can also see that is continuous high amplitude slow waves. In REM sleep, it will be like more or like awake with eye movements, and it will have the mixed frequency and mixed voltage pattern. So in this table, we can clearly see when the child is preterm, in every phase there will be like trace discontinue pattern only. As the child grows and matures in awake stage, the trace discontinue will decrease, and the interburst interval decreases, and it tend to become continuous. By 36 to 40 weeks, it will become continuous. When you come to sleep, you can able to appreciate sleep only in the when the child is nearing term. That the trace discontinue will change into trace alternate pattern. So by the time it will have two types of pattern, either trace alternate or continuous slow wave sleep, high amplitude slow wave sleep will be there. In awake stage, it will be like purely continuous, and that REM with active sleep will be more or like awake state, but with frequent eye movements and more of atonia. So this is the awake record of the 44 weeks, that is conceptual age. This chronological age is about 1 month old child. Here you can see, if you see the background of this, here it is an awake state. We can see that continuous background, but here the frequency it is, we can, there won't be alpha. Alpha will reach only by 1 year like time. Here it will be like previous, the background will be predominantly theta delta complexes. More of here the frequency you can see is background frequency is nearly 3 to 4x here you can see. So it is like and the amplitude will, the voltage will be lower than the sleep. I'll slow the next show the sleep record of the child. Reactivity will not be at the one, reactivity will tend to start occurring only after 3 months to that 3 to 4 months of age. Yes, sir.
So the child reaches down your head, child, whether sleep or wake transitions, sleep. At that time, you will start seeing the reactivity. So towards the end of the page, you see attenuation with myogenic and articulate. So it's not that they won't be reactive. Understand?
Yes, sir.
The wake transitions are what will be seen better once the child reaches down. And the reactivity will still be appreciated. The extent of attenuation of the posterior dominant may not be very apparent
Yes.
up until around 40 to 44 weeks. You start seeing.
So in this awake record, yes, sir. In the when in the time you can see partial reactivity also. So you can see that eye movements and the artifacts, movement artifacts. Along with you can see that reactivity also. Reactivity will start to appear, and it won't be very apparent like very like 1 year old child, but it will start to appear, and the reactivity will increase as the age increases. So this is same child. We have seen the sleep record. So here you can see that continuous slow wave high voltage delta complexes. This is slow wave sleep with high voltage. It's a sensitivity of 20 microvolt. So here it will be more approximately, it's more than 100 microvolt voltage will be. So here but the wave is continuous. So it is high voltage slow wave sleep. Other thing we can see in this age is trace alternate pattern also we can see. And another one thing I have to tell is, so this is also a same age of the sleep pattern of the same child. You can see that continuous sleep. So some with attenuation you can see in between. So either it can be trace alternate pattern or high voltage continuous slow wave sleep. The REM sleep. So another thing is important is REM sleep. So in term and neonate, the REM sleep will be high. So when the child nearer term, the non-REM sleep will take over. So in the pre-term and terminal, REM will be like 80% and non-REM will be only 20%. When it reaches term, it will be like 50%. So by the end of 1 year, non-REM will reach 70%, and by the end of 2 years, REM will be non-REM will become 75 to 80%. So REM sleep we can identify mainly like it will be like mixed frequency, like more or like awake stage with low amplitude mixed frequencies thing, and there will be a low muscle tone we have to see, and the child will have irregular breathing. So, and the rapid eye movements are very important. Rapid eye movements we can see. Next thing is the child may have some phasic movements. That is atonia, muscle tone will be decreased, but in between the child will have limb twitches like movement or some grimacing can happen that can be picked up in EMG. So this is the this is a 43. This is a 1 month old child. Here you can see actually. So it is like not high voltage waves. It is like mixed frequency, and it is of low voltage thing. And you can see eye movements. Rapid eye movements can be seen here with some. So it is mainly of mixed voltage and fall frequencies, mixed frequencies with eye movements. So this is a REM sleep seen there. So this is this is how we have to identify the REM sleep. Another thing is like we have to see any hypotonia we can see in EMG. That are the thing. And the respiration. The respiration will be like irregular respiration, and periodic breathing can be seen in REM sleep. This is how we can identify the REM sleep in the EEG. So after things, what are the normal transients we can see in that preterm and term? That is called grapho elements. So now we can see some normal transients in the EEG of preterm. That is in the very preterm we can see beta delta complexes. So that is like in the delta there will be like superimposed fast activity. Also we can see some temporal theta bus. When it reaches late preterm, we can see some frontal soft transients and frontal some rhythmia, like frontal delta and all we can see. When it reaches term also, we can see some frontal wave transients, some temporal short waves also we can see. We'll be explaining one by one. So first thing is beta delta complexes. So it is seen in preterm. So it is a slow delta with superimposed fast activity. It mimics delta complexes, delta breast pattern of the NMDR encephalitis. But it is a normal pattern seen in preterm. So it occurs yearly. It occurs appears start to appear by 24 to 30 weeks, predominantly in central regions, and it start to disappear by late preterm. So next thing is temporal theta burst. So it is a rhythmic theta activity seen over the temporal region. So it is like theta frequency like 4 to 7 hertz. So it starts appearing by 26 27 weeks. Also it tends to disappear by when the child reaches term. It also disappears. Another thing is encoaches frontalis. This is a short frontal transients. So it is mainly seen in frontal polar region. It mainly occur in non-rapid sleep. It starts appear when the child reaches term, that is by 34 to 35 weeks, and disappear by 46 to 48 weeks. That is exactly by 1 to 2 months of chronological age. Another thing we can see near term is anterior dystonia, that is like frontal delta. We can see that's like polymorphic delta waves in the frontal region along with short frontal transients. These are the things normally we can see in the term child, that is around term period. Another thing is positive temporal surface. That is like positive wave. It occurs like brief wave. It is mostly it will occur in quiet sleep. That is non-REM sleep. It also start to appear by 30 to 34 to 35 weeks and decline by 30, 44, 46. So the important things about these grapho elements are these type of transients will disappear by 1 to 2 months after the neonatal period. So this is in how it occurs when from the preterm to neonate. So what and all happens? So that so when if you see that frequencies of the background frequency will slowly by increase, and the amplitude. So it initially where the high amplitude will tend to decrease as the child matures. Another thing is that trace discontinuous pattern will become the trace alternate pattern, and that grapho elephants and transients like uh, delta beta complexes will start to appear in preterm and end by term. And by the term, some antidistal frontal delta and frontal sharp complexes can appear around term. These are the things we must very carefully look when we see the neonatal and neonat around preterm and term EEGs.
But that you are applying first tablet.
Yes.
Okay, the first amplitude which actually reduce.
Yeah,
As the periods of discontinuity, that amplitude will tend to increase, so that the posterior dominant rhythm becomes more of a continuous time.
Here the amplitude I am telling is it is more of a burst amplitude. That burst amplitude will decrease when as the child matures, but at a period of attenuation that amplitude will tend to increase, and the EEG will tend to become continuous when the child reaches 10. So next we will move on the EEG in infants from 2 months to 1 year, how it looks. So background by 2 months, the background will become continuous in all states. Both in awake and sleep, it will become continuous. And in initial 2 to 3 months, it will be primarily delta theta only. But it is diffuse, I think. And when it reaches, when it child ages till when it reaches by 1 year, the posterior dominance will come and alpha frequency will tend to take over. So 2 to 3 months says that posterior that rhythm will be more of 3 to 4 hertz range only. So by 3 to 6 months it will reach 4 to 5, and by 1 year it will become 5 to 6. So there's a minimum. So this is a maximum the child can reach, but minimum we think is like by the end of we can keep like example you can keep it as a twice. Like by the end of 2 year minimum the child must have or 4 frequencies, and by the end of 3 years it must have 6 hertz background frequency. Why the posterior dominant rhythm occurs? This occurs due to a pattern of myelination, because the posterior dominance, initial the dominance is seen in posterior region because our myelination happens from posterior anterior. So initially posterior structures get myelinated, and slowly that anterior myelination. So the complete myelination takes by only by the end of 2 years. So like that way, that dominant rhythm also will appear, start from posterior dominant rhythm. So from as the myelination increases, that frequencies, thalamocortical circuit will develop much, and that frequencies increase. Uh, So synchrony also. So initially there will be mild interhemisphere asynchrony can happen in 2 to 3 months. When the child reaches nearby by 1 year, adult-like synchrony is attained. Symmetry also remains same. So both synchrony and symmetry will be like adult-like and will become more synchronous symmetry by 1 year of age. Here the this is an age of a 2.5 month old child with conceptual age of 51 weeks. Here you can see that posterior dominant rhythm of 3 hertz. 3 to 4 hertz. That's a good reactivity. You can see that with attenuation and acceleration with good reactivity, we can see it's an awake record with some movement artifacts also. So here that for this age, this is a normal background. Here that waves are only 3 to 4 hertz frequency background. This is for this age, it is normal. So coming to the sleep of that same child, here you can see the continuous waves. But here you can, so when I saw that term child, that will be a high voltage. That voltage of the sleep was also will come to the continuous sleep also will slowly decrease as the child ages. But you can see that continuous waveforms, slow wave sleep in the sleep pattern.
Not the big problem.
Mhm.
So you see some periods of beta activity and then some periods of blackening.
Yes, sir.
So you're not sure with the absence of the electroencephalogram as well as taking it. You cannot be sure that this is always very well be runs. So with the absence of EOG and I cannot see that it's like okay.
So the another thing important here is that electroocologram is nothing. So without electroocologram, it is difficult to tell slow wave or REM sleep, because here you can see some period of some mild attenuation also. So it is not. So moreover, it is looking like slow wave sleep only. But we have to see electroocologram and other features also when we comment on the sleep EEG.
Even if
Sorry, it's at 2 months old child EEG. Sorry. So this is the awake record of the 9-month-old child. Here you can see that background frequency is around it is around 4 to 5 hertz it has reached, and also the reactivity is seen well better here in the CG. Along some artifact.
and this second reactivity seen.
Yes, sir.
First 3 seconds you're seeing the theta,
Theta.
and then you're seeing that is the phase of the
So here you can see the reactivity can be seen, and some myogenic and movement artifacts are there in the EEG. Then another important thing when you interpret that infant EEG's drowsiness and sleep, we must be very careful. So because some transients can happen, like hypersynchronous theta rhythm, that is hypnagogic hypersynchrony can happen. It is high amplitude. Some delta waves will appear. So we must not think it as an epileptic form discharges. So it is a drowsiness. Here it is an example of hypnagogic hypersynchrony. So when the child changes from awakes to sleep stage in the drowsiness, we can activate of this high amplitude delta waves. So in between, you can see some spiky component at the end. So this is not a true IEDs. So this normal hypnagogic hypersynchrony can have this type of transients. Also another one example also. Here it is an 5-year-old, 6-year-old child. So here you can see that high amplitude delta. Here you can see some at the end of the text spike. But this is actually normal thing. But here also you can see some abortive at the start of the thing. So some abortive discharges are seen. So there is some embedded IEDs also embedded in is present in the cell. This is actually a case of left middle cranial fossa lesion. But some IG trait like some abortive spikes are there. Along with that, hypnagogic hypersynchrony. So when we interpret hypnagogic hypersynchrony, we must be very careful in differentiating true IEDs and the some spiky component that is normally present inside the hypnagogic hypersynchronic pattern itself. So this is just like summary what happens in infancy when the child ages. So the REM sleep tends to come decrease, but it will remain around it will become around 30% in at 1 year. But in non-REM sleep, it slowly increases. Also, that sleep sleep wake that sleep cycle, that is time between active sleep and quiet sleep also changes. Initially, it will be around 60 minutes. For each every 60 minutes, there will be a active and quiet sleep. When the child ages, the cycle will become 90 minutes cycle, the sleep cycle. So at that 1 month, so then slowly that sleep structures will start to appear. So sleep spindles are the earliest thing to appear. So it will start to appear by, so rudimentary thing will appear in 1 to 2 weeks itself. The well formed will appear by 1 month. Then sleep spindles appear and it will become slowly. It also matures when the child.
Because typically start to appear by 6 to 8.
Yes.
Wait,
Yes.
but these spindles, the rudimentary forms are actually appreciated.
So actual thing, the rudimentary from the sleep spindles start to appear from 6 to 8 weeks. So stages of sleep. So by around 3 to 6 months, then then fragmented sleep consult in the more distinct. We can clearly see in non-REM and non-REM period, and but it is shorter sleep cycle, like 50 to 60 minutes. And when the child grows, it will become 90-minute sleep cycle. REM sleep will be more of a low ambient mixed frequency EEG pattern and more continuous and desynchronized than non-REM sleep. It will look like awake state, but with reduced muscle tone and rapid eye movements. Non-REM sleep will be more organized with sleep structures will start to appear from 6 to 8 weeks. First thing is about sleep spindles. It will start to appear from 6 to 8 weeks, and it will become more prominent in the later in the infancy. So spindles usually start appear by 1 month. That is about 6 to 8 weeks, and vertex rudimentary form will appear by 2 months, 2 to 3 months, and K complex will start appear by 3 to 5 months. So from spindles, by its well-formed spindle, we can see from only by 6 to 8 weeks. And after that, the initial part of spindles will be more of asynchronous pattern. The full symmetric and synchronous will attain by only 2 years of age. So before that, asymmetric and spindles are normal for that child. So when the child grows, there will be initially like long spindles will be there, and it will become mature short spindles, and finally it will become symmetric and synchronous only by 2 years of age. So if you see asymmetric spindles after 2 years of age, it indicates some abnormal thing. So before that, it is a normal thing. Here you can see that sleep of a 6-month-old child. It is the end to stage of sleep. Here you can see that asynchronous and asymmetric spindles. Here the spindles are more over that right side, and here it's from asynchrony is that here happening that is the asynchrony and asymmetricity between the right and left hemisphere. So that we can see the clearly here in this.
Spindle frequency and
Spindle frequency is it's like more or alpha 10 to 12 hertz, and duration will be like ideally 3 seconds, 0.5 to 3 seconds. But in child, it can frequency can extend also, so it can have long spindles and some extreme spindles also. Here I can see here the sleep spindles are very extended, and it is more than 8 seconds. It is very long spindles. So for 5 months, infants can have this type of long spindles. But when it happens in some older child with high amplitude, this extreme spindles are indicative of encephalopathy pattern. So it is normal in infantile age. But if you see in older age, we must think of some encephalopathy patterns.
not delayed maturation.
It indicates delayed maturation. So here's a summary table of that sleep structures. So spindles is initially irregular asynchronous at 2 to 3 months. By it will become regular and increasing in amplitude will tend to become more centroparietal by 3 to 6 months. And by 6 to 12 months, it will become typical 12 to 14 as frequency with predominant well-formed centroparietal pattern. Vertex will be initially small and immature low amplitude, and it will become sharper and more prominent by 1 year. K complex also by 2 to 3 months, it will be absent in 2 to 3 months. It will start appear only by 3 to 6 months, and it will be well formed by 9 to 12 months with high amplitude and clear morphology. So this is a 2.5 month old child. With here you can see the rudimentary vertex. So this is low amplitude. It is looking very fragmented. It is not very sharp. It is like initial form of vertex started appearing. This average pattern, you can see small spiky component of the central region vertex face. So another way we can see in infants is like cone wave. These are the rudimentary K complex. This is occipital monophasic transit seen in the uh, seen in the occipital region. So the thing is, it is like rudimentary K complexes. So it will be present in three after three. It can start appear by after 3 to 6 months, and it can present in up to 1 to 2 years. So coming on to then what happens when the child matures to 1 to 3 years. So by 1 to 3 years, there will be a full continuous pattern will be attained. The 1 to 2 years, there will be a frequency posterior dominant will be around 6 to 7 Hz. But minimum there will be by end of 2 years 4 Hz frequency must be there. If there is it is less, it is delayed ontogeny. By 3 years minimum there must be a 6 Hz thing. And this, there will by 2 to 3 years the symmetry will be like adult like synchrony, and the background will be very symmetric, and sleep structures also will become more symmetric and synchronous after 2 years. And there will be a strong posterior alpha rhythm will start to appear, and there will be a good attenuation with the reactivity of alpha rhythm. That and all we can see after 1 year. So this is an uh, EEG of the 2-year-old child, and here you can see very good 78 Hz. Here we can see more of like sorry. Here you can see more. In a 4 to 5 Hz frequency. Nearly it is some it happened 5 to 6 Hz also. So it is normal for. So by 2 years of old, we must have minimum 4 Hz background, and there is also good reactivity period of attenuation with and some myogeny movement artifacts are there, but we could appreciate reactivity also here. Period of attenuation and ascendancy we can see. And it is symmetric and synchronous, and reactivity is seen here. So by 2 years. So here the what happens to sleep? Sleep will be REM sleep will be more of same like low voltage mixed frequency, and non-REM we can clearly see the clear staging like N1, N2, N3 pattern of sleep one can be. By N2 pattern will be like predominantly with sleep architecture, and N3 pattern will be like very delta high voltage delta wave sleep, slow wave sleep will be in N3 pattern. And sleep signals will be, as I told, it will be very symmetric and synchronic, and it will be more over centroparietal region. And vertex waves will become very sharp, prominent with bilateral synchrony. And K complexes will be well formed by this age. So here this sleep spindles in 1 year 8 month old child. Here you can see that so it is more like short spindles. Moreover, it is looking symmetric, and it is tending to become an symmetric and synchronous by what? It will become full symmetric and synchronous by 2 years. So it is moreover looking symmetric and synchronous only here. It is a cone wave. In third second, you can see here, you can see the cone wave also we can see. That is a rudimentary K complex. So this is a vertex. Vertex become very sharp in the toddler age. Here you can see the very sharp uh, phase reversal at central electrodes, and you can see that sharp vertex, mature vertex, we can see in that 1 to 3 years of age. This is a well-formed K complex biphasic mountain-like waves, very large amplitude waves with around 500 milliseconds. So well-formed K complex also will seen in this age group. Next thing is from 3 to 5 years, what are the things we are chasing? So same background will be like that the posterior dominant rhythm will tend to become more of alpha frequencies. But one thing we have to remember, like by after 3 years, it will tend to become alpha rhythm. But 3 to 6 years of age, in between, there will be some slowing can be that. 50% can be theta rhythm. Same like 6 to 8 years, that 25% theta rhythm intermixed slowing can be that is normal. And symmetry will be at least fully symmetric and synchronous, and there will be strong reactivity will be there. Less than 20, it is like around less than 25%, and this is less than 50% theta there. So it is like background in 5 years old child. So here you can see moreover like frequencies 78 we can see clearly, and there is a background with some reactivity that some attendance is there with some movement artifacts, myogenic artifacts, and that this is a awake record with a good alpha background we can see in this age. So here REM sleep will be more of same like low voltage mixed frequency with rapid eye movements, and non-REM sleep also will be same only. But more thing is like spindles, vertex, and K complex will be well formed in this age group. That's the one thing we have to remember. So here we can see spindles at 5 years, very symmetric and synchronous, and null short common of the spindles we can see. So in both hemispheres we can see this is the spindles that will be expected by 3 to 6 years of age. So when it moved to pre-adolescent, like 6 to 12 years of age, so the posterior dominant rhythm will be purely alpha. It will moreover reaching adult form. Like by we can approximately by 10 years, it will reach around 10 nets. That's the thing. So in between, mild slow activity can be seen. Like so symmetry will be completely symmetric and synchronous with strong reactivity. So sleep vertex waves will become less prominent. The vertex will be very sharp in the children, very 3 to 6 years. Then that will become less prominent compared to that age. K complex will be still be well developed like adult like morphology. So in adolescence, when it becomes adolescence, so it will become like same like fully continuous form waveforms with adult frequency of alpha posterior dominant 10 to 12 hertz frequency. In between, some slowing 10 to 50% slow waves can be seen. That I will explain what is that, and it will be fully symmetric and synchronous and with full reactivity. And here also we can see normal good spindles with vertex and K complex signal can be seen. That N3 stages of sleep will tend to become decrease when we reach adolescence. So normal trance is seen in adolescence. That's very important from childhood thing. First is I think is hypnogabic hypertension that will start away with 3 to 6 months of age and it fades by adolescence. Another thing we can see is like in sleep we can see some positive ostial transients. It's a normal thing. So it begin by 4 to 5 years and it is continuous in teens and adults also. And then important thing is posterior slow effect. That is a small some slowing can be seen in background. So starts appear by 8 years and it tends to disappear by 20 years, but it can present sometimes late also. The another transients we can see is in adolescence and young period is 14 and 6 is positive spikes, mu rhythm and lambda waves. I will be explaining about some things in here in later slides. So here you can see that it's a 17-year-old person with, you can see here, very good reactivity. When the eyes are closed, that alpha is coming like very good alpha rhythm with of around 9 to 10 nets. And in here, in between, you can see here some slowing, you can see some looking like some slow waves. But these waves are normal for this. This is called posterior slow waves of youth. So we must not mistake it as a some spiky spike IEDs. So here the alpha is looking, so alpha can be somehow short component. This slow waves are formed due to is a mixture of alpha. So you can see small alpha inside this also. This forms a slow wave. So it is in average. So record, you can see the same thing. It looked like slow wave, but it is seen in hospital region. It is a normal slow wave. See, this is called posterior slow wave of youth. And another thing is lambda waves. Lambda waves are positive, similar to post. As we see, we know post we are seen in sleep. It is lambda waves seen in awake record. It is due to like scanning. It appears due to scanning of when we scan that positive transients can occur. So here you can see some transients. So looking like some sharp waves, but it is a normal transient seen it. So if when we look into that, this is an common average. Here after same thing. Here you can see the positive waves. These are the normal positive transients. That is called lambda wave seen in awake record. This also we can see in awake record. And another thing is mu. Mu is like similar to alpha rhythm. Alpha rhythm that is seen predominantly over the central region. So it is like the positive will be like sharp comb like component and will be downward will be like smooth curved component. So it will look like some mu waves. This also can be due to, this is normally we can see. This is due to activation of somatosensory cortex, but it can be made disappear when we wiggle our contralateral thumb. This wave will disappear. This also can seen in normal adolescent period. So these are the normal trances we start to appear in adolescence. So we must be very careful when we look at the adolescent EEG. So this we must not interpret these transients as IEDs. That is a very important thing. And though then the adult form remain moreover stable. It will adult EEG as all we know. I will not be explaining much about adult forms. So it will become more transient. Then after 40 years, what happens is this EEG that everything that alpha rhythm will tend to decrease. Then in elderly, so the posterior dominant rhythm decreases after 40 years. That is up to the frequency of by every decade it will decrease by 0.5 hertz. So more than 70 years you can see some low frequency, like not very low. It is at the lower end of alpha we can see. So but reactivity is very precise. That the amplitude also tend to become low when the person becomes old. So in sleep, uh, we can see still space.
You can change this here. Can see sometimes that one is going. Frequency is low. We take what they are mentioning is that range of alpha. When we say that it is 8.5 to 13, that's the physiological range of alpha. That range can come down by 0.5 hertz per decade. It's not that the variable alpha frequency will come. The range of alpha frequency ranges between 8.5 to 13 hertz. That frequency range reduces by 0.5 hertz.
So in the elderly, so normal alpha range will be 8.5 to 13 hertz. So that range comes down, but still it will be in alpha range only. It decreases by 0.5 hertz per decade. So it can from some can have 9, some can have 10. So if the person had 13, it slowly comes to 11 or 10, like that way. There sleep also they're more or similar, and it will be remain similar only, but the vertex and all will become little bit smaller. That is the only thing, and this is seen in awake. Some normal, some minimal temporal, benign temporal slowing can seen in awake record also. So these are the normal things. So we cannot, if the patient had a small minor slowing in the temporal region, it can be normal. When it is age concerned and persistent slowing, you must think it as an abnormal thing. So this is an age of a 93-year-old person. Here you can see that good alpha around 8 to 9 hertz. So it is well good alpha at this age with some good reactivity also. So when the eye open and close, there's attenuation and good attenuation is happening. So here you can see that vertex. So vertex is it will not be very prominent like young age, but still you can see the vertex, but it will have low amplitude. This is a vertex seen at the 95 years old person. So I'll just explain in one table. So from when the child from preterm to then it will when the age increases, background will become from discontinuous pattern to by term it will become continuous awake, and it will become well organized, and the frequencies, main thing is you have to see the posterior dominant rhythm. The frequencies will increase 3 to 4, and it will become sound, so 8 by 3 years, and that in sleep trace discontinuous pattern will be present at preterm, and it will become trace alternate at that time, and it will become a mature sleep pattern by 1 to 2 years, and with formation of very good spindles and K complexes after 3 months of age. And transience is very important. So in the preterm, you can see like delta brushes like pattern, and the delta brushes disappear by term, and by term you can see some frontal transience. By 1 to 3 months, you can start seeing hypnagogic hypersynchrony, and from then after that you can see by post lambda and all in the age increases. So from 3 to 5 years you can see from in adolescence you can see positive slow of youth and other positive transients like 14 6 transients. uh, then by a background becomes very good. By adolescent it will have very good alpha rhythm, but it in elderly tends mild that not, it's still in alpha, but the range comes down, and mild in temporal slowing can occur normally in elderly age. This is the normal thing seen. Then finally, I will tell about one few points about amplitude integrated EEG. So this is thing we are amplitude integrated EEG is like when we are suppose it will be helpful in NICU like when we are long term EEG monitoring. So it is like we'll be using only specific small less electrodes along with that specific filter. We will reduce the keep the frequency between 2 to 15 hertz, and we will log it. So we'll keep a logarithmic scale between here 5 to 100 microvolts we will be keeping here, and the paper speed is very important, 6 centimeters per hour. That means in 1 hour it will move only 6 centimeters. So in that we can see 6 to 8 hour pattern in single page. So suppose here see here it is a normal what is that here we will how we plot is like here if you see normal one EEG wave, we'll take the peak to peak. So it is the maximum peak to peak here, and it is the lowest peak to peak. That maximum peak to peak amplitude will be that higher amplitude, and the lowest will be kept like this. So the waveforms will be like here some up and down like graph. It will come like this. So the advantage is like we will see that one day long 24 to 36 hours EEG in single in single page. The main thing usually in staging hypoxic ischemic encephalopathy, she is monitoring non-convulsive status epilepticus in children. It will be helpful. So from this, they are classified this pattern into how. So normal pattern will be between, normal pattern will be between the minimum of 5 microvolt and 10 microvolt, such that. So here, if it is 5 and 10, the normal EEG, that fluctuations will be this thing only. If it is discontinuous, sometimes this waveform can come below this. It will go down below this. If it is very low, what is let is suppressed pattern maximum that less than 10 microvolt, all the phases, that waves, that graph will be below this 10 microvolt. If it's very flat, suppose if it is in like the child is having fully suppressed EEG, the waveform will be we can see it is very suppressed like this. In best attenuation, you will see the best of high. In between, you will have high. In between, you see lower also. It will not be like in between the stages. It will some will be like up range, some will come down. So it is like best attenuation pattern. In continuous status epilepticus, non-continuous status epilepticus, it will be like evolving frequency. Like frequencies will change like waves. So you can see from low, it is evolving frequencies like high amplitude. The amplitude is evolving. So these are the things we change in epileptic. Main classification, first initial 5 only. So 5 types of things we can identify with this amplitude integrated EEG. So then it will be useful for in NICU patients, see NICU child in main monitoring like non-convulsive status epilepticus or burst, long burst suppression pattern. It will be very helpful for this. This EEG will be helpful. And I'll conclude by saying this mature final slide. So main thing is from the when the child from when we mature, from the child grows from 1 year to 20 years, that background will change from slowly. That background posterior dominant rhythm frequency increases, and in the adolescence we can see some transients like posterior slow wave, lambda waves, and mu rhythm, and so non-REM and REM sleep phases. So when the child ages, non-REM sleep will be more prominent when the age increases. And from also that, see, non-REM will increase and REM will come decrease. And transients, at what age, what are the things occurring? That's very important. So 6 to 8 weeks, spindle start appear, then vertex start appears by 3 months, and K complex appears by 5 to 6 months. So and other transients, that are the things we must see when we closely monitor it. So why it is important is when if you know this, if so main thing is if there is any delayed ontogeny, any deviation from this, we can pick. When we know the normal thing, we can pick up the abnormal or delayed ontogeny from that EEG pattern. So learning the ontogeny is very important. We must know the evolution process. Then only we can know what is normal and what is abnormal, and from that we can interpret correct. Thank you.
Not what the education for me, and now you're going to answer the education. And then of course, your technologist has to be very alert to mention as whether the child is active sleep, whether the child is sleeping, or the child is awake. Posterior dominant appearance, usually when you start seeing it by 3 months, you can actually associate it with the posterior. That is why it's called posterior dominant. We should be able to appreciate the reactivity very well. The reactivity appears by the end of 1 month. Very well, you can appreciate the react. Also, you should start seeing the sleep wave transitions. So, unless the main markers of delayed ontogeny would be presence of discontinuity, the EEG, at least if you have preterm EEG patterns which persist well into 40 to 44 weeks. So, presence of discontinuity could be a basically. The other thing could be the presence of low voltage. The voltage during the periods of quiescence between the bursts could be generally more between 10 to 25 microvolt if it is 40 to 44 weeks. Beyond 44 weeks, the periods of quiescence should not be there. The amplitude should be in the alpha range, 40 to 60 microvolt range. So that is the posterior dominant. The voltage should be between 30 to 60 microvolt. So the discontinuity, then amplitude, reactivity, and then of course your sleep wave transitions. These are the basic points which you should look at when you are separate pediatric. And then of course, what are the ranges which happen the posterior dominant over time? the changes which can happen. In what age you tend to see this normal theta activity intermixed with the alpha. So we say that around 1 to 3 years, your predominant frequency between the range of theta. Then 3 to 5 years, your theta activity is expected to be less than 50%. So by 3 years, the minimum frequency you should see is 6, but you should be seeing a well established alpha by then, which should be well reacted. But the frequency can be up to between 1 to 3 years. More than 50% can still be theta activity in your awake loop. And between 3 to 5 years, that activity is expected to be less than 50%. By 5 to 7 years, it should be less than 25%. But beyond 8 years, fully slowing that you should be seeing are the slow wave only. Understand? And persistence of asynchrony. If you see one hemisphere which is persistently slower in comparison to the other hemisphere, or asymmetry, that is one hemisphere is more attenuated in comparison to the other hemisphere. Across the age, it is abnormal. If you see a persistent left hemispheric attenuation or left hemispheric swing, you should comment it as such. You should correlate it with the imaging findings. So you should know if you're doing a neonatal EEG, you should know the Afghan reading and all at the time of delivery. What was the indication for doing? What are the concurrent medications? So why this period of nanoparticle maturation? Why this period of bursts happen with periods of peace?
That burst is due to that.
You said it is a preterm pattern. What is the basis for that? Because the nanoparticle maturation is just starting.
So why stimulation that brain sensor stimulation?
You're saying that doesn't react. So why does the period of burst happen and then you have a period of
some sensory, any stimuli can the child move by some twitches or movements
to make a sleep awake transition. So the general reason that is thought about is the fact that the GABA is hyperpolarizing only after a certain age, that is beyond around 4 to 6 weeks only. The transition from to hyperpolarizing GABA happens. Before that, it is a depolarizing GABA. You understand? It's also referred to as the excitatory GABA-minergic transition. Generally, when we hear the word GABA-minergic receptors, we know it is hyperpolarizing and it mediates its activity through the chloride channels. Right? Causes hyperpolarization. Whereas around 4 to 6 weeks, you can have a predominant depolarizing effect. So one of the reasons you get permanent injury because of the hypoxic ischemic encephalopathy is because of this absence of this shift from depolarizing GABA to hyperpolarizing GABA. So when that gets delayed, that is when you have persistent sequelae as a consequence of hypoxic ischemic encephalopathy. That is one of the reasons you also get neonatal seizures also as a consequence of which the depolarizing GABA which tends to create this kind of. And it is the transition from depolarizing GABA to hyperpolarizing nature of the GABA-minergic neurons that mediates this the transition from passive discontinuous pattern to continuous. Okay, so that is some electrophysiological data that is correct. This is one of the reasons that it is also suggested that we give a diuretic like bumetanide, which mediates the chloride channels in order to prevent persistent sequelae of hypoxic ischemic encephalopathy. Apart from the other mechanisms like hypothermia, continuous EEG monitoring, which is indicated to prevent to watch for electrographic seizures, which in babies who are on this hypothermia as part of cerebral protection. Similar thing, bumetanide is also being suggested as one molecule. It is a diuretic, which helps to mediate that chloride activity within the neurons. Okay. So that is a electrophysiological.
Thank you.